the amazing panelists that we have today are going to be able to answer all of your questions. So please type your questions on the Q&A chat box. Unfortunately, Dr. Silverman, you have to leave earlier today. He won't be able to make his amazing comments and answer the questions, but if you have any specific question for him, you can reach him by email as usual. So just save the date for the World Congress of Pediatric Cardiology and Cardiac Surgery. This is going to be amazing, guys. It's going to be a great opportunity to see all of you in person again. So please save the date, August 27th to September 1st next year, 2021. And we have next week our meeting of fetal cardiology. So please join us next week. And beginning of May, we have Dr. Silverman talking about isomerism. It's going to be very interesting. And now with you, Dr. Anderson has a small introduction, and then we are going straight to the topic, the system venous abnormalities. Thank you, guys. Sasha, are you finding the video? Yes.
Well, good afternoon to you all, ladies and gentlemen. It's a pleasure to be with you all again. And we're now going to start our next series of seminars on the anatomy of the congenitally malformed heart. And as with our previous series, I'm going to be joined by Diane Spicer, who's going to be showing you her excellent video demonstrations of the anatomy. And we're going to have Justin Tretter join us from the Cleveland Clinic, who's going to share with you his experience now with using computed tomographic analysis. And then Adrian Crucian will be joining us again from Birmingham Children's Hospital. And Adrian will be discussing with you the surgical significance of the features we're going to emphasize. So for our first series, we're going to share with you 3 presentations where we're going to look specifically at venous anomalies. And we're going to be doing these on a monthly basis because we have quite tight schedules over the summer period. But we hope we'll be able to continue these sessions because they are proving as rewarding for us as we hope that they are for you. And I'll demonstrate that to you during today's presentation, because I learned a great deal myself whilst I was preparing the material that we're going to share with you very shortly. So in this first series of sessions today, we're going to discuss the problems with systemic venous anomalies. Then in the next session, which will come in the month of May, we will discuss with you pulmonary venous anomalies. And then in June, we'll finish this first series with a detailed discussion of the sinus venosus defect. Now, I know we've discussed that before, but we'll move on in this series and we'll share with you what we've learned during the time we've been having these earlier episodes with the Congenital Heart Academy.
Mi chiudi la porta? No?
So, in the first of these sessions, as you see, we're going to be discussing abnormal systemic veno-atrial connections. And if we are to understand the abnormal variations, then what we should begin with is by emphasizing that we have to take account of the atrial arrangement. Now, we've emphasized that to you before, but it's particularly important in this setting, because it follows that you can only have a truly normal arrangement when we have either usual or mirror-imaged atrial arrangements. And arguably, even in the mirror-imaged atrial arrangement, the situation is not entirely normal, but then it is normal for those mirror-imaged arrangements because the overall systemic veno-atrial connections themselves will be mirror-imaged. But here we come to the hooker. When the atrial appendages are isomeric, then any sort of veno-atrial connection will be abnormally arranged. Because if you have two morphologically right atrial appendages, then obviously you can never have normal pulmonary veno-atrial connections. If you have two morphologically left atrial appendages, you can never have normal systemic veno-atrial connections. But if you have isomeric atrial appendages, the venous drainage can be usual or it can be mirror-imaged. And that is why nowadays we emphasize again and again that when we distinguish between the atrial chambers, we need to do it on the basis of the morphology of the appendages, not the veno-atrial connections. So you will all know this by now. The first step in the diagnosis of any patient with a congenitally malformed heart is to establish the presence of morphologically right and morphologically left appendages before we can presume that there is either the normal or the mirror-imaged arrangement. We then have to come back to the problem that we've been discussing now throughout the last year. How do we distinguish between the atrial appendages? And hopefully by now, you've all come to appreciate that the feature we use is the extent of the pectinate muscles relative to the vestibules of the atrioventricular junctions. Once you have established that the appendages are isomeric, of course, I think it's now fair to say that you as clinicians will always be able to distinguish the subsets of right and left isomerism. That gets us back to the situation, how do we distinguish the atrial appendages? And it's also necessary to distinguish the isomeric variants from total mirror imagery, because total mirror imagery itself is not normal. It is the mirror image of normal. So strictly, that is heterotaxy, since heterotaxy is anything other than usual. So we need to start off by looking at how we distinguish the atrial appendages and what is the significance of that. When we're doing that, of course, we take note of what's going on in the overall patient. And in this respect, bronchomorphology bronchopulmonary morphology is particularly important. So you as clinicians, when you're assessing the veno-atrial connections, keeping mind of what's going on with atrial arrangement, you need also to look at bronchial arrangement. Why is this important? Because on some occasions, when you have usual atrial arrangement and you have usual veno-atrial connections, you can still have disharmony between the cardiac arrangement and the bronchial arrangement. And we'll look at that in one specific subset. But when the veno-atrial connections themselves are anomalous, And there are also malformations within the heart itself. And in our experience, it's very rare to find disharmony between what is going on with the bronchopulmonary arrangement and what is going on with the atrial appendages. So that is why, for you as clinicians nowadays, you should always take note of the bronchial arrangement. And we can look now at a specific case that Diane is going to show you to emphasize the significance of looking at the atrial arrangement in terms of the appendages, the veno-atrial connections, and the bronchial morphology.
The apical component of this specimen with isomerism of the left atrial appendages has been moved, and when it was in the chest, the apex was to the midline. The bilateral morphologically left atrial appendages are hugging the arterial trunks as they leave the ventricular mass, and here we see the right-sided appendage with its tubular nature and the narrow junction to the venous component, and the left-sided appendage, also tubular in nature, with its narrow junction to the venous component. The right-sided atrium is somewhat hemodynamically dilated, and when we look at its roof, we can see that the superior caval vein is entering this right-sided morphologically left atrium, and the inferior caval vein is joining its floor. Opening the atrium, the pectinate muscles do spill out of the appendage in this morphologically left atrium, but they do not extend to the crooks of the heart, and the remainder of the vestibule is smooth. Here we can see the coronary sinus and the flap valve at the floor of the oval fossa, so that this specimen has the superior and inferior caval veins joining the right-sided morphologically left atrium. Looking at the left-sided atrium from the back, here we see the left pulmonary veins and the right pulmonary veins joining this left-sided morphologically left atrium. The inside of the atrium shows us a smooth vestibule with the pectinate muscles confined to that narrow junction and within the appendage. At the atrioventricular junction where it's cut, you can see the coronary sinus just there running in the left-sided atrioventricular groove. If we review from behind, the superior and inferior caval veins join the right-sided morphologically left atrium, and the pulmonary veins from both the left and right lungs join the left-sided morphologically left atrium, showing us that this case with left atrial isomerism has quasi-usual veno-atrial arrangements. Looking at the arterial trunks, the aorta is arising anterior and leftward of the pulmonary trunk, and when we look at the short axis, the right-sided ventricle is morphologically left, and the left-sided ventricle is morphologically right, with the aorta arising from it and supported by a complete muscular infundibulum. If we look at the topology of this specimen and we tilt it so we can look at the septal surface, only the palm of my left hand can fit on the septal surface with my thumb in the inlet and my fingers in the outlet. This specimen has biventricular and mixed atrioventricular connections with left-hand ventricular topology and quasi-usual veno-atrial arrangement. This specimen with isomerism of the left atrial appendages also had increased trabeculation within both ventricles, and at autopsy the lungs and the trachea were removed from the heart. And here we can see that the isomeric bronchial pattern mirrors the isomeric left atrial appendages, so that both lungs have two lobes, one upper and one lower lobe, and the bronchial pattern is that of a morphologically left bronchus, so that they are both long hypoarterial bronchuses. And here we can nicely see the pulmonary artery segments on each of the lungs.
So what Diane has now shown you is that in that patient, that heart you've just seen, in which there were obviously isomeric left atrial appendages, the veno-atrial connections were in fact usual. But that does not mean that the patient himself or herself had usual atrial arrangement. In fact, the presence of those isomeric left atrial appendages tells you that the atrioventricular connections were mixed. Half of the heart was concordantly connected, half of the heart was discordantly connected. The key point was that there was left-handed ventricular topology. You all know that the situation in which you most frequently find left-handed ventricular topology is congenitally corrected transposition or discordant atrioventricular connections. That particular heart, however, did not come from a patient who had congenitally corrected transposition, but rather a patient having left isomerism, mixed atrioventricular connections, and left-handed ventricular topology. So how easy is it for you now, as clinicians, to diagnose the presence of isomeric atrial appendages? Well, speaking as an anatomist, I believe now it is very easy. But to emphasize that point, Justin is now going to show you how you as clinicians, probably now using computed tomography, are able always to diagnose the presence of isomeric atrial appendages.
Before we look at a CT data set of a patient with isomeric atrial appendages, let's first briefly review normal cardiac anatomy with usual atrial arrangement. So this is a CT data set of an adolescent patient. And as we start to dissect into the heart, we can appreciate the base of both atrial appendages on the left and the right side. And if we look at the left-sided atrial appendage, we see that it's finger-like. We see the pectinate muscle contained within the atrial appendage. We see a large, smooth-walled body of the left atrium leading up to the vestibule of the mitral valve. So this is a morphological left atrial appendage. And this is in contrast to the right-sided atrial appendage, which is broader base. And because of the contrast timing, we don't have as nice of a view of the tricuspid valve. But if we rotate this right-sided atrial appendage into its long axis, we can appreciate that the pectinate muscle is extending down all the way down to the vestibule of the tricuspid valve. So this broad-based right-sided atrial appendage with pectinate muscle extending all the way down to the vestibule of the tricuspid valve is a morphological right atrial appendage. We can also appreciate, as we look at the exterior of both the atrial appendages, here that right atrial appendage, again, broad-based atrial appendage, as opposed to this left-sided atrial appendage, which has a hook appearance, a smaller finger-like appearance of this morphological left atrial appendage. So this is a younger infant that has abnormal cardiac anatomy. We're looking anteriorly at the chest wall, and we'll start to dissect into the heart, and we can see both the right-sided atrium and right-sided ventricle, and we can easily appreciate some of the muscular structures of this right-sided ventricle, including the moderator band that's helping us to identify this as a morphological right ventricle. We can see the coronary artery, which is coming off of this great artery, which is arising over from the left ventricle, but wedged down in between the AV valves. So this identifies this as the aortic root. This is the pulmonary root, which is arising from the right ventricle. We see a perimembranous ventricular septal defect right near the hinge line of the tricuspid valve, centrally located. And if we pay attention to the right-sided atrium, we can see the right-sided superior cable vein coming into it. We can see a right-sided inferior cable vein with the paddocks draining into this right-sided atrium. However, we also see a right-sided pulmonary vein draining into this right-sided atrium. And if we look at the interatrial septum, we can see that there's a relatively large secundum atrial septal defect. And through the defect over to the left-sided atrium, we can appreciate pulmonary veins draining into that left-sided atrium. So we have partial anomalous pulmonary venous drainage into this right-sided atrium. And then if we rotate, however, into the short axis and we interrogate the atrial appendages, then we can appreciate that this right-sided atrium is in fact this is a morphological left atrial appendage, even though it's dilated, related to the fact that it has both the entirety of the systemic caval venous drainage along with some of the pulmonary venous drainage into this right-sided atrium. We can see that this dilated atrial appendage, the pectinate muscle, is contained within with a smooth body leading down to the vestibule of this right-sided atrium. So this is a morphological left atrial appendage on the right side. So now looking the surgeon's view down at both of the atriums and the AV valves, now looking at this left-sided atrial appendage, this looks more typical for a left atrial appendage, being small and finger-like or tubular, pectinate muscle contained within the appendage with a smooth body leading of the atrial wall leading down to the vestibule of this left-sided AV valve. So even though dilated, again, a morphological left atrial appendage on the right side, so we have isomeric left atrial appendages. So this patient who many would refer to as having heterotaxy, more specifically has isomeric left atrial appendages in the setting of ipsilateral pulmonary venous drainage. And if we look externally at the right-sided atrial appendage, we can see that even though it's dilated, it has this hook-like appearance as shown in this left-hand panel. And then if we look at the left-sided atrial appendage, also with that hook-like appearance, but the more normal, smaller, tubular appearance of the left atrial appendage. So both morphologically left atrial appendages, however, the one on the right being somewhat dilated. And interestingly, as we interrogate the bronchial morphology in this patient, if we look at the right-sided bronchi, the first branch of this bronchi is up here. So it's a early branching of this bronchi as opposed to this left-sided bronchus, which has a longer segment until the first branch. And if we look at how the pulmonary arteries relate to the bronchi, we can see that the right side is eparterial and the left side is hip arterial. So even though in the heart we have isomeric left atrial appendages, we have this unusual combination of usual bronchial arrangement of the appendages or bronchial arrangement. And this is actually a case that we published to highlight the point that the additional term of heterotaxy doesn't add to the diagnosis if we describe the cardiac anatomy, including the isomeric left atrial appendages and the usual bronchial arrangement.
So what we've now determined is that in order to work out what is going on with anomalous veno-atrial connections, we have to start off by diagnosing the presence of usual atrial arrangement and then appreciating the anatomy of what are normal veno-atrial connections. So obviously, normal veno-atrial connections come back to the morphologically right atrium. We can be a little more specific than that. Not only do they come back to the morphologically right atrium, but as they enter the morphologically right atrium, they are confined within the boundaries of the systemic venous sinus. And that's also an important point because we now know that we can recognize the boundaries of the systemic venous sinus by the presence of the so-called venous valves. Having identified the venous valves, not all of the venous valves are seen, but Diane is going to show you that you can see them with increasing frequency in the congenitally malformed heart if you know what you're looking for. Within those confines of the systemic venous sinus, we find superior caval vein, inferior caval vein, and of course, the coronary sinus. And it's anomalies of those three venous channels that we're going to be discussing in the remainder of today's presentation. But let's emphasize again the normal arrangement of the morphologically right atrium. Now here's a still picture of the morphologically right atrium. Very shortly, Diane's going to be showing you a moving picture with one of her beautiful video clips. But you see immediately, I hope, in this still image, the essence of the morphologically right atrium. And that is the extent of the pectinate muscles within the appendage relative to the vestibule supporting the leaflets of the tricuspid valve. And by now, I hope we've established that the essence of the morphologically right atrium is that those pectinate muscles telling you what is the appendage extend all the way around the vestibules, and they reach to the crux of the heart. We need, of course, to take account of the other components of the morphologically right atrium. And there is a very small part of the body, the part of the primary atrium during development, that is committed to the morphologically right atrium as the primary septum divides the body of the atrium into its right and left components. And in the morphologically right atrium, the body is sandwiched between the septum and the valves guarding the systemic venous sinus. And there you can see in this heart both of those valves, the right valve, left valve. The right valve, as Diane will show you very shortly, is prominent as the eustachian valve and the Thebesian valve. But in this heart, you can also see the left valve, which is tightly adherent to the body. And then within those venous valves, we have the openings of the superior cable vein, the inferior cable vein. There you can see the Thebesian valve, the eustachian valve rather. And there the coronary sinus guarded by the Thebesian valve. So Diane's now going to put that into context, and she's going to emphasize for you the location of these venous valves which mark the boundaries of the systemic venous sinus. And then Justin will show you the features of the systemic venous sinus as you can now see them using computed tomography.
Here we're looking at the outward appearance of a morphologically right atrial appendage with its blunt or triangular tip and the broad junction with the venous component. The superior cable vein is joining its roof and the inferior cable vein its floor. Along that broad junction, if we open the atrium, we can see that smooth systemic venous sinus between the cable veins. And if we look at the remnants of the venous valves that we can sometimes see in the atrium, at the roof of the atrium, this flange of tissue sometimes remains, and this is a remnant of the left venous valve. Sometimes it remains very prominent, and there is a little cavity up under this area. Other portions where you can see remnants of the left venous valve are towards the body of the right atrium, so between where the inferior cable vein joins the atrial floor and the inferior aspect of the oval fossa. These areas sometimes leave trabeculations where the left venous valve has remained prominent. The other venous valves that we typically associate with the systemic venous sinus are the eustachian valve and the Thebesian valve. So this eustachian valve is not very prominent. There are a few little fenestrations in that valve, and the coronary sinus shows us a very small Thebesian valve, so just a little piece of tissue along the inferior aspect of the mouth of the coronary sinus. Sometimes the eustachian valve can be quite prominent, as it is in this specimen. Here we see the oval fossa and the coronary sinus, and this is the eustachian valve, which is sometimes known as the valve of the inferior cable vein. You can see that it is quite prominent in this specimen, and there is a small fenestration along the lateral aspect. The Thebesian valve as well is quite prominent and nearly covers the entire mouth of the coronary sinus in this specimen. As I mentioned, the left venous valve can be prominent in such a fashion that it remains as a complete flap of tissue over the floor of the oval fossa. So here you can see the fenestrations in that prominent left venous valve, and as it creates another partition over the flap valve at the floor of the oval fossa.
This is a normal adolescent CT data set, a fluoroscopic-like image looking directly anterior at the cardiac silhouette. And we'll fill this in with the endocast image of the heart, and then we'll rotate into a right anterior oblique view where you can appreciate the broad-based right atrial appendage extending down towards the right atrioventricular junction, seen here with the right coronary artery coursing between, which is separating between the right atrium and the right ventricle. And we can appreciate the superior and the inferior caval vein. And if we continue to rotate, we'll start to see that terminal groove, which is spanning between the superior to inferior caval vein. And then we'll transition into a virtual dissection image looking at the cavity of the right ventricle and the right atrium. We can appreciate the base of the right atrial appendage here. We can see the mouth of the superior caval vein. Here is the interatrial septum, including the oval fossa. And then we'll open up the inferior caval vein. So spanning between the superior to inferior caval vein is that venous sinus, which is guarded by the venous valves, including the eustachian valve. And there's a much smaller body of the right atrium between this venous component, this venous sinus, and the interatrial septum as compared to the much larger body seen in the normal left atrium. And then we'll rotate from this right anterior oblique view, and we'll rotate. So we're looking directly anterior and rightward at the anterior rightward aspect of the right atrium and its broad right atrial appendage, seeing its long axis from its tip down to its base, with the pectinate muscle extending all the way down to the vestibule of the tricuspid valve. And then we'll start to come and dissect posteriorly towards us, towards our view, into the caval vein. So we're right there dissecting through that terminal crest, which is spanning between the superior to inferior caval veins, and directly behind that is that venous sinus, which again, so seen here, and again is guarded by the venous valves, including the eustachian valve.
So now we've looked at normal anatomy. What we're going to try to do during these presentations is relate that to what we now know about development. And so what I'm going to emphasize to you here, to understand abnormal veno-atrial connections, we need to appreciate that initially the systemic venous tributaries themselves are bilaterally symmetrical. And I'm going to show you that knowledge of that development provides the background for understanding all the anomalies we're going to be discussing in what remains of this particular session. And I'm going to use these interactive PD files. These are now available. Our work with Jill Hickspoors as the first author, Wout Lammers. You'll remember we looked at these throughout last year's sessions. They prepared these from the University of Maastricht in the Netherlands. This work is now available for you in a paper published in Communications in Biology. And we've illustrated the findings from Carnegie stage. CS is standing for Carnegie stage 10 through to Carnegie stage 23, which represents the end of the embryonic stage of development. So here we're looking at Carnegie stage 12. And I've segmented here for you the atrial component along with its venous tributaries. So there in purple, see the umbilical veins, which are bilaterally symmetrical. And there in gray, you see the vitelline veins, also bilaterally symmetrical. They come together and they join what we call the hepatocardiac channels. Then also at this stage, bringing back the blood from the embryo itself, we have the cardinal veins. And they then come together and they drain through the horns, what we're going to call the systemic venous sinus, and they drain into the body of the atrium. And the body of the atrium is part of the primary heart tube, and already it is expanding by the process of what we call ballooning, and it is the ballooning that will produce the atrial appendages. Now we're looking at this from the front, and you can see the cavity of what is the atrioventricular canal. And you'll remember that at this early stage, the atrial chambers connect only to the developing left ventricle, and the atrioventricular canal is left-sided relative to the overall ventricular loop. Now, what I want to emphasize for you at this stage is the bilateral symmetry. And I can show you that by taking the same reconstruction, turning it round so that you can see it from the back. So now, looking at it from the back, now you're looking at the back of the body of the atrium, and I want to emphasize another important point. Because they're shown you in green in this image. Very shortly, we're going to change the color and it's going to come pink, but that is the body stalk. This is how the body of the atrium is connected to the pharyngeal mesenchyme, and we call that the dorsal mesocardium. And the pulmonary vein will eventually enter the heart through this body stalk, through the dorsal mesocardium. At this stage, you see it is in the middle of the body of the atrium, but you can also see opening into the body of the atrium are the left sinus horn, right sinus horn, and there you see the venous tributaries, which are bilaterally symmetrical. There, the cardinal veins, the umbilical veins, the Vitelline veins. Now, the key point at this early stage is that both sinus horns are opening into the body of the atrium. Now, the key stage of normal development, which permits us to prepare a morphologically right and a morphologically left atrium, is what happens to this systemic venous sinus. So here we are at Carnegie stage 12. Very shortly thereafter, within one stage, we see that major change. And this is a shift rightward of the tributaries of the systemic venous sinus. So now you see that the systemic venous sinus itself, which is confined within those venous valves, is only connecting with the right half of what was the body of the atrium. You see now that the left sinus horn has separated itself from what will be the cavity of the left atrium. And now, showing you in pink, we see that dorsal mesocardium. If you look very carefully, there's a little blob on that pink dorsal mesocardium, and that is the entry of the pulmonary vein. And what you see very nicely is that the entry of the pulmonary vein is sandwiched between the right-sided and the left-sided systemic venous tributaries. And we're going to come back to that at the end of our presentation today. But you see that because of this rightward shift of the venous tributaries, there is now a space between the body of the atrium and the left sinus horn. I can show you that in one of the episcopic data sets that was prepared by Tim Mohan. It's exactly the same stage of development, but now we're looking at it from the front. So you're looking now into the cavities of the developing right, the developing left atrial chambers. And very nicely there now, you see those venous valves, and they are marking the junction between the systemic venous sinus, the body of the right atrium, and the ballooning appendage. An opening within those venous valves, we have the opening of the superior caval vein, the inferior caval vein, but what I want to emphasize is the entry of the left sinus horn, which now is to the developing right atrium. But particularly important is that it has invaginated itself into the left atrioventricular groove, and in so doing has produced separate walls from itself and the larger part of the body of what was the primary atrium, but is now the left atrium. There is the primary septum, and the primary septum is partitioning the body of the atrium, so that almost all of it goes onto the left side. At this stage, there's a little bit of the body of the right atrium which is between what will eventually be the sinus and the left venous valve. And you've already seen in Diane's presentation to you how the left venous valve applies itself to the right side of the atrial septum. But the key in terms of what we're now going to discuss in terms of the anomalies is the fact that that space between the wall of the left sinus horn, the wall of the left atrium, is retained throughout development. So here at the end of the embryonic period, Carnegie stage 23, you see the cavity of the left atrium, the left sinus horn, and if I blow up for you the space between there, the left atrium, left sinus horn, you see that there are two walls. The wall of the coronary sinus is always separate from the wall of the left atrium, remembering that the left sinus horn will become the coronary sinus. And that is going to be particularly important when we consider anomalies of the systemic venous tributaries. So what are the possibilities? Since we know there are three venous tributaries, it follows we can have anomalies, the superior cable vein, anomalies, the inferior cable vein, and anomalies of the coronary sinus. Very rarely, all three can be anomalously connected, and that is what we call totally anomalous systemic venous connection. And I'm going to today's presentation by sharing with you a view of a heart which has totally anomalous systemic venous connection. And this is the first one I've ever seen. We're also going to discuss this very unusual entity that is called the levoatrial cardinal vein. But let's begin by looking at the commonest anomalous systemic vein, and that is persistence of the left superior cable vein. Now, this raises another important point, because when most frequently we see persistence of the left superior cable vein, although we consider that as an anomaly, the blood coming through the persistent left superior cable vein enters the morphologically right atrium. So although the persistence of the vein is an anomaly, the venous drainage is normal. But I'm also going to show you that on occasion, we can have persistence of that left superior cable vein when there is anomalous drainage. So here we need to distinguish between anomalous connection and anomalous drainage. So let's start off by looking at the commonest of all the anomalous systemic venous findings, and that is persistence of the left superior cable vein so that it drains through the coronary sinus into the morphologically right atrium. And that's what Diane is now going to show you.
This specimen has a persistent left superior cable vein. There was absence of the left brachiocephalic vein, and you can see the persistent left superior cable vein taking its usual position where it crosses the bifurcation of the left pulmonary artery from the pulmonary trunk, and also crosses the junction of the left atrial appendage with the body of the left atrium. These are the left pulmonary veins, and folding them back, you can see a clear line of demarcation in this area between where the persistent left superior cable vein joins the coronary sinus and the left atrial wall. Looking into the left atrium, which I don't have opened extensively because of the persistent left superior cable vein, you can see that there is no interatrial communication, so the coronary sinus is not unroofed. And if I place my probe in the dilated coronary sinus, we can clearly see that there is no interatrial communication and that there are separate walls between the left atrium, the persistent left superior cable vein, and the coronary sinus. Looking at the right atrial aspect, the coronary sinus is quite dilated as that persistent left superior cable vein is draining to it. Here we can see the flap valve at the floor of the oval fossa is intact, and there is our dilated coronary sinus and the tricuspid valve hinge point. If we look at a short axis cut from the base of the heart, this shows us even nicer the separate walls between the persistent left superior caval vein and the body or vestibule of the left atrium. Here are the left pulmonary veins, the interatrial septum, and the morphologically right atrium with the pectinate muscles all the way around to the crux of the heart. Tilting this a bit, you can see that the coronary sinus is quite dilated, and when I place my probe in there, it's nicely illustrated that the walls between the persistent left superior caval vein and the coronary sinus are separate from the left atrium.
So, we've now shown you the persistent left superior caval vein draining to the morphologically right atrium. We can also have anomalies of the right superior caval vein, and of those, perhaps the most frequent is for the right superior caval vein to be absent, but in presence of the persisting left superior caval vein. And that brings us again to the situation of connections versus drainage. So here I'm using some of the still images from a case of Diane's to show you what happens when we have presence of the cranial component of the superior right caval vein, but its proximal part is absent. But look what happens to the venous drainage. It passes through the brachiocephalic vein, and then it drains into the left superior caval vein. Let me close up on this fetal example of Diane's to show you that when we look at the right side, we see that there is no right-sided superior caval vein. You can recognize, however, that this fetus had an obvious morphologically right appendage, so there was usual atrial arrangement. So when we look at it from the left side, you can see on the left side the morphologically left appendage, confirming that we do indeed have usual atrial arrangement. But what Diane has done here is she has emphasized for you the course of what is happening to the venous drainage. Because that left superior caval vein, which you'll remember is receiving the blood from the right superior caval vein, is now coursing through the coronary sinus, and it is draining its blood into the morphologically right atrium. So here we have an anomalous right superior caval vein, its proximal part is missing. We have an anomalous left superior caval vein in that it drains through the coronary sinus into the right atrium, but the systemic venous return from the head will still reach the morphologically right atrium, so the drainage is normal. But that is not always the case. So we can have absence of that proximal superior caval vein, and I've shown you that despite that, the blood can drain normally to the right atrium, but not always. And so here is a very interesting case. Now, this case shows you some of the advantages of the Congenital Heart Academy, because this case has been shared with me, as you see, by Dr. Madan Madali and his colleagues who work at the Royal Hospital in Muscat in Oman. And this is an exquisite set of computed tomographic images that has been shared with me by Madan and his colleagues. And what you can see here very beautifully is that, again, we have the right superior caval vein, which does not connect to the morphologically right atrium. I had Madan and his colleagues check the atrial arrangement, and they have confirmed for me that in this case, there was indeed usual atrial arrangement, as in the case we looked at just a moment ago. But now look at what's happening to the venous return. Because now, as in that previous case, it is crossing from right to left in the brachiocephalic vein. It's coming down to the heart in the left superior caval vein, but this time, left superior cable vein does not drain through the coronary sinus into the morphologically right atrium. In this instance, the left superior cable vein is connecting anomalously to the roof of the morphologically left atrium. So now we not only have anomalous connection, we also have anomalous drainage. So all the systemic venous return from the head and from the arms in this instance is entering the morphologically left atrium. Madden and his colleagues showed that the venous return from the abdomen, however, was entering the morphologically right atrium through the inferior cable vein. So there we have absence of the proximal superior cable vein, in this case with the left superior cable vein receiving the brachiocephalic systemic venous return and connecting and draining in anomalous fashion. And that was because that left superior cable vein was unroofed. And we'll return to that when we discuss anomalies of the coronary sinus. But let's move on first, and let's look also at this situation, which we just discovered, and think of how the right superior cable vein can get into the morphologically left atrium. Now, I had always thought that the most obvious way that could happen was, as you see here, through the A sinus venosus defect, because of anomalous connection of those right pulmonary veins, which are connected to the superior cable vein, but retaining their connection to the morphologically left atrium. I now know that there is another way in which the right superior cable vein can get into the morphologically left atrium. And Diane is now going to show you the heart in which the right superior cable vein is connecting into the morphologically left atrium, not by virtue of a sinus venosus defect, but by virtue of the position of the atrial septum. And this is the heart that I've learned a great deal about during the preparation for this particular session. In this first video, Diane is going to show you this heart, and she is going to concentrate on the way that the right superior cable vein is entering the morphologically left atrium.
This is a very interesting little heart that has concordant atrioventricular and concordant ventriculo-arterial connections. Here you can see the pulmonary trunk and the aorta spiraling in usual fashion from the ventricular mass. The right atrium has a bifid tip. Part of it looks tubular, but there's also a broad junction with what would be the venous component. When we look inside of the atrium, here we see a terminal crest and the pectinate muscles extending around the right atrioventricular junction. This tiny orifice represents the coronary sinus, and you can see that it extends in the left atrioventricular groove in the usual fashion. This specimen also has an atrioventricular septal defect with separate right and left orifices, so that here's the superior bridging leaflet and the inferior bridging leaflet adherent across the crest of the septum. There's the leading edge of the atrial septum, and there's a very large so-called secundum type of atrial septal defect. You might have noticed that the inferior cable vein does not join this right atrium, nor does the superior cable vein. So that if I probe the roof of the atrium, there is this small diverticulum that is blind ending and does not join any other structure. But right beside it, we have what looks very much like a right superior cable vein. The right superior cable vein gives rise to a very large azygous vein. And when we look at the left atrium, here we see the tubular nature of the appendage and its narrow junction with the atrial vestibule, which is itself smooth There's the narrow junction of the appendage with the pectinate muscles confined to the appendage. This specimen also has a persistent left superior caval vein that drains directly to the roof of the left atrium. You might see that little ridge of tissue there. That represents where the wall was interrupted between the persistent left superior caval vein and the left atrium. Here is the left side of the atrioventricular septal defect, and there is our so-called secundum defect. The inferior caval vein or the hepatic veins are joining the floor of this left-sided atrium, and there was also a prominent vessel that extended from that inferior caval vein or hepatic vein into the abdomen. Here we see another opening, and this is actually the mouth of the coronary sinus, and I can probe this opening up to that right-sided superior caval vein, so that this right-sided superior caval vein drains into the left atrium with walls separating it from the right and left atrium, and it drains into the coronary sinus. And if I probe that coronary sinus from the left atrium, we can see that it exits that small orifice that I showed you earlier within the wall of the right atrium. So very interesting veno-atrial abnormalities in this case, and I actually probably should point out that the pulmonary veins did drain into the left atrium via solitary pulmonary veins from each of the lungs, so that I can probe directly from the left atrium the right and left pulmonary veins. So we have a heart with usual atrial arrangement that has the right superior caval vein draining into the left atrium with walls separating it from both the right and left atrial cavities, and it drains into the mouth of the coronary sinus within the left atrium.
Now I'm going to come back to that particular heart that Diane has shown you at the end of the presentation, because you will have noticed that in that particular heart, the inferior caval vein was also draining into the left atrium. Now that is an anomaly in itself. It's been described, you've just seen an example, but it is exceedingly rare. And usually it is associated with the sinus venosus defect. But in the heart you just saw, it was not associated with the sinus venosus defect. We also have to distinguish this variant from persistent eustachian valve. So let me show you those two mechanisms. Here you see the situation where we have persistence of that eustachian valve. And that is deflecting, in this instance, all the blood through the inferior caval vein across the oval fossa into the left atrium. And in this setting, it's very important to distinguish between the persistent eustachian valve and the boundaries of the oval fossa. This is the much rarer variant that you've just seen, along with connection of the superior caval vein to the left atrium. There you see the inferior caval vein. It's draining directly into the left atrium. And we're going to come back to that, and I'm going to show you another example of that to finish today's presentation, because that is due to anomalous location of the atrial septum. But before we get to that, let's shift tack just a little bit, and let's look at the commonest anomaly of the inferior caval vein, because I'm sure you're all aware that the most common lesion involving the inferior caval vein is interruption with azygous return of the venous return from the abdomen. And I'm sure you're also all aware that most frequently we find that with left isomerism. But here, I should emphasize again that we can find azygous return of the inferior cable vein in the setting of usual atrial arrangement. Now, oftentimes we can also find that when the lungs are showing left isomerism, when there are multiple spleens, and when there's biliary atresia. This is the situation when the arrangement in the heart, however, is normal and there are no intracardiac anomalies. When there are intracardiac anomalies, then almost always, in my experience, azygous return, the inferior cable vein, is associated with left isomerism. And that is what Diane's going to show you now. She's going to show you a nice example of azygous return in the setting of left isomerism.
This specimen has the liver attached and has isomerism of the left atrial appendages. The arterial trunks are spiraling from the ventricular mass in the usual fashion, and there are concordant ventricular arterial connections. Here you see the right-sided morphologically left appendage that is hemodynamically dilated, and here is the left-sided morphologically left appendage. The liver is attached and is of a fairly usual shape with the smaller lobe to the left and the larger to the right. The patient does have bilateral bilobed lungs, so that there is the fissure between the upper and lower lung on the right and the fissure between the upper and lower lung on the left. The patient also had bilateral hyparterial long bronchuses, so that the lung and bronchial anatomy was consistent with the atrial anatomy in that they were all isomeric. This specimen has azygous continuation of the inferior cable vein. So here we can see the azygous vein over the root of the left lung and running into the abdomen. As well, there is the left aortic arch running to the left of the azygous vein and into the abdomen. If we look at the back of the liver, the gallbladder is very hypoplastic, just this little structure here, and you can see that it lies in the midline. Here is what would have been the analogous to the caudate lobe, and in this area is where you would see the hepatic segment of the inferior cable vein running through the liver. So there's typically a fossa in this area where the hepatic segment of the inferior cable vein runs. You can see that that is interrupted, and we have azygous continuation with the abdominal drainage via the azygous vein.
So, looked at anomalies of the superior cable vein. We've looked at anomalies of the inferior cable vein. So now let's concentrate on anomalies of the coronary sinus. But remember, the coronary sinus itself is the left sinus horn. So we've looked at persistence of the left superior cable vein draining through the coronary sinus. And we could also consider that as an anomaly of the coronary sinus. But there are other lesions that can involve the coronary sinus. The coronary sinus can be atretic due to persistence of the Thebesian valve. Its wall can be fenestrated, and that is part of what we call unroofing of the coronary sinus. So now Diane's going to show you these entities. She's going to show you a nice example of atresia. Then she'll show you this spectrum of fenestration and unroofing, and they demand that somehow those walls that normally separate the coronary sinus from the left atrium, both of those walls are deficient, and that leads to this spectrum of fenestration to unroofing of the coronary sinus.
This specimen is from a fetal death in utero at about 34 weeks gestation, and the patient had transposition and a double inlet left ventricle. So here we see the aorta arising from this rudimentary right ventricular chamber on the anterior superior aspect of the heart. Here is our morphologically right atrial appendage, so there was usual atrial arrangement, and the superior cable vein joining its roof. The brachiocephalic vein was of good size, and you can see that there is a persistent left superior cable vein that is actually quite tiny. So that this persistent left superior cable vein takes its usual position across the bifurcation of the left pulmonary artery from the pulmonary trunk and across the junction of the left atrial appendage with the body of the left atrium. We can see that the coronary veins are running in the left atrioventricular groove and to the coronary sinus, as you would expect. And here again is that tiny persistent left superior cable vein also joining the coronary sinus. The inferior cable vein is entering the right atrium here, and that subthebesian sinus adjacent to it is quite thin-walled and dilated. When we look at the inside of the right atrium, here is the flap valve at the floor of the oval fossa, which is deficient, so there is an atrial septal defect. And there is our eustachian valve. The subthebesian sinus, as I mentioned, is dilated. And if we go a little closer, we can see that there is no identifiable lumen for the coronary sinus, and that this is a very small remnant of the thebesian valve just there. So there is atresia of the coronary sinus that was most likely drained via the persistent left superior cable vein, which is extremely tiny in this case, and this was most likely the cause of the intrauterine fetal demise, with this persistent left superior cable vein draining the coronary veins, eventually becoming too tiny to do its job. Here we're looking at the right atrioventricular junction in a heart that has hypoplastic left heart syndrome with severe mitral stenosis and aortic atresia. Here is the superior cable vein joining the roof of the right atrium, and that's the bifurcation of the azygos vein. The inferior cable vein has not been opened across, so there we see it as it joins the floor of the right atrium. This is the eustachian valve, and there is the coronary sinus. The flap valve at the floor of the oval fossa is well formed and is deviated quite leftward with a probe patent oval foramen. There is the anterior inferior muscular rim, and within the muscular buttress there is a defect, and this is a vestibular atrial septal defect. Also, between the right and left atrial walls and across that interatrial fold, here we see striated areas, and this is actually a defect or an interatrial communication outside the confines of the true atrial septum that is acting as a pop-off for the pulmonary venous drainage. These defects can occur in this interatrial fold and as well between the walls of the coronary sinus and the left atrium. If we look at this tiny left atrium and into the tiny mitral valve, there is the mitral valve orifice, and just above it, the tiny vestibular atrial septal defect. Looking at the flap valve at the floor of the oval fossa, it is deviated well leftward, but probe patent. And within this interatrial fold between the inferior cable vein and the left atrial wall, there are the fenestrations or interatrial communication that is acting as a pop-off for the pulmonary veins to drain into the right atrium because of the severe mitral valve stenosis. We're looking into the opened right atrium. You can see the pectinate muscles around the right atrioventricular junction, and this specimen has a common atrioventricular junction. There's the right side of the common junction, and there's the left with the crest of the muscular ventricular septum. This is the opened inferior cable vein, and there is where the superior cable vein joins the roof of the atrium, with a small remnant of a venous valve crossing its opening. Looking at the atrial septum itself, there is a defect, or a so-called secundum defect, at the floor of the oval fossa, and there is the leading edge of the atrial septum. This large dilated area here is actually the coronary sinus, and when I place my probe through there, you can see that I am in direct communication with the left atrium. So that here is the inferior cable vein as it joins the floor of the right atrium, and there is our interatrial communication. This specimen has a persistent left superior cable vein, and it is directly joining the roof of the left atrium. So here's the left atrial appendage, and you can see this small rim of tissue as the persistent left superior cable vein joins the roof of the atrium. This is where the walls of that persistent cable vein should have formed to communicate directly with the coronary sinus and close it off from becoming an interatrial communication. Those walls failed to form or were interrupted during development, so that we end up with the persistent left superior cable vein joining the atrial roof directly, and the coronary sinus not having completed walls or being unroofed, as we typically say, with an interatrial communication at the coronary sinus.
So now, to complete our assessment of the anomalies of the systemic veins, we must return to this strange entity that we call the levoatrial cardinal vein. In reality, it's neither levo, atrial, nor cardinal, but that's what we call it. So what is it? In fact, it is an anomalous pulmonary to systemic venous collateral channel, and it connects the normally connected pulmonary veins into one of the systemic venous tributaries. And typically we see it in the setting of mitral atresia or severe obstruction of the left atrium. So this is what it looks like. I can show it to you in this cartoon. There you see the mitral valve is imperforate. We can also have this in the setting of absence of the left atrioventricular connection. Most frequently, we find it in the setting of the hypoplastic left heart syndrome. But Diane's going to show you an example with mitral atresia. And in this setting, it is a collateral channel from the roof of the pulmonary veins draining into the left atrium to a systemic venous channel. And Diane's now going to show you, to finish her demonstrations, an example of the levoatrial cardinal vein.
Here we're looking at the left pulmonary veins as they join this left atrium. Here's the left atrial appendage, and you can already appreciate that the left atrium is of a quite small size. There was mitral valve stenosis and a small left ventricle in this patient who had a common arterial trunk that arose entirely from the right ventricle. We can see the superior cable vein here with a very nicely sized left brachiocephalic vein, and joining that brachiocephalic vein is this vertical vein. The pulmonary veins are joining the left atrium, as is this vertical vein, and this is a so-called levoatrial cardinal vein. It does not run in the same position as a persistent left superior cable vein. It would run right in this area over the junction of the left atrial appendage with the atrium. So it's a bit more lateral in its placement when it forms and serves to drain the pulmonary venous circulation when the left atrium is stenotic as well as the mitral valve. And this also happens more so in cases where there is mitral valve atresia. And I will show you the right atrium just to show that the coronary sinus is of normal size. It's not dilated, and this is not a persistent left superior caval vein. And there's the coronary sinus running in normal fashion in the left atrioventricular groove.
So we've now looked at all these anomalous connections in isolation, but I'd like to finish by sharing with you some words about totally anomalous systemic venous drainage. In my experience, this is particularly rare. We find it, as you might imagine, in the superior and the inferior caval veins, along with the coronary sinus, all drain into the morphologically left atrium. We have to distinguish that from left isomerism. When we have left isomerism, of course, all the systemic veins are draining anomalously because both of the atrial chambers have a morphologically left appendage. And most of the examples described of totally anomalous systemic venous drainage, in fact, have left isomerism. But it can be found very rarely in the setting of usual atrial arrangement. And I had never previously seen an autopsy case showing us totally anomalous systemic venous connection. But in fact, you have now seen that case because the heart that Diane showed you, concentrating on the connection of the right superior caval vein to the morphologically left atrium, also now we appreciate has totally anomalous systemic venous connection. And this is one of the features that became apparent to us as we went through these cases that we are preparing for you today to demonstrate to you the features of anomalous systemic veins. So let me finish by showing you the pictures that Diane took of this particular case. So here it is. She's outlined with those red dots the boundaries of the right systemic venous sinus. What you can particularly see nicely is that the right-sided atrial appendage is obviously morphologically right. There's a very nice terminal groove between that morphologically right appendage and the right-sided systemic venous sinus. And there you see the terminal groove. Coming into the systemic venous sinus, on the right side, we have the superior caval vein and we have the inferior caval vein. But now it looks here as though the venous drainage is in fact normal. But Diane has opened out that morphologically right atrial appendage. You can see very nicely now the pectinate muscles are extending to the crux. There really is usual atrial arrangement, but look at the site of the deficient atrial septum. The entirety of that right-sided systemic venous sinus is to the left of that atrial septum. The superior caval vein, the inferior caval vein are both draining into the morphologically left atrium. You've seen this before in Diane's demonstration, but I can demonstrate it to you now by turning the heart around and showing you the picture that Diane took to show us the cavity of the morphologically left atrium. There you see the deficient atrial septum. There is an atrioventricular septal defect. There is also an oval fossa defect. But relative to the location of that atrial septum, we can also see the systemic venous return. And there is the left superior caval vein. And you will immediately see that the left superior caval vein is unroofed. The walls that should normally separate the left superior caval vein from the cavity of the left atrium are not there. You can also see the inferior caval vein obviously opening to the left of the location of the atrial septum, but look here. That big hole that you see there is the orifice of the right superior caval vein, and it has entered through the right atrioventricular groove, so that along with the left superior caval vein, the inferior caval vein, it's draining into the morphologically left atrium. There is no question that in this heart we have totally anomalous systemic venous connection. But I'd like to emphasize to you one additional point, because there are the openings of the pulmonary veins. and they are opening centrally into this morphologically left atrium relative to the connections of the venous tributaries. And that to me is very reminiscent of this picture that I've shown you already, this early stage in which we have symmetrical connections of the sinus horns to the body of the atrium. So there, the left sinus horn, the right sinus horn, and there, between them, the opening of the pulmonary veins. And to me, the heart I've just shown you reflects the fact that the atrial septum has grown in such a way that it's put the entirety of the venous tributaries into the developing morphologically left atrium, giving us, in this instance, totally anomalous systemic venous connection. And it's due to an anomalous position of the atrial septum rather than, as I would previously imagined, the sinus venosus defect. So what we've tried to show you today, the bottom line, the knowledge that we now have of normal development permits us to suggest ways in which all of these anomalies can come about. And so I do believe now we can give you a rational explanation for all the anomalies involving the systemic veins of the normal heart.
Thank you very much, all. It was a very nice session. We learned a lot for sure. We have a couple of questions on the Q&A chat box, but I'd like to listen to the comments of the panel before we go to that.
We can't start our videos, Grace. It says Shasha is stopping us.
Let's see if I can do something.
Or at least I can't start mine. I see Diane and I can see Justin.
While we're waiting, I'll just let you guys know that my internet connection is unstable, so I may go in and out.
So I can answer Dr. Selvin's question. He asks, is a coronary sinus present in right atrial appendage isomerism? So Rohit Lumba, advocate, had looked at this feature with Diane and Professor Anderson and myself, and has shown that it's absent in 100% of the time, since it's a left atrial structure, since it runs in the normal morphological inferior left AV groove. So that should be a reliable feature to help distinguish when you're looking at right versus left atrial appendage isomerism.
I can see that I've started my video now.
Yes, you are. We can see you now. Okay, Adrian, do you want to comment something?
Thank you. It's been a very rich session. Thank you very much. Very interesting demonstration and specimens. And I would encourage participants to go back to the video when it's available on the YouTube channel, because a couple of the hearts that Diane showed are really, really interesting. If we follow the development, we'll see that the systemic venous sinus gathers both horns, but the veins eventually they behave differently. Justin just told us about 100% possibility of an absence of coronary sinus, which is a rare rule for cardiac morphology, whereas the superior caval vein and inferior caval vein do not behave like that, although the horns move together, shift together to the right. And it's also a matter of what happens with the atrial septum. It's not only the shifting of the systemic venous sinus, but probably the crux comes to the point that if we talk about veno-atrial connections and compare with the other instances in cardiac morphology where we use the term connections, atrioventricular and ventricular arterial connections, there we have segments. So if we want to talk about veno-atrial connections, it would be useful to have atrial segment and venous segment. And I think this is one of the issues that we can discuss about veins as segments. So we can apply the terms connections. and I'm sure Professor Anderson will discuss that. One additional thing I wanted to ask, whether the discussion around appendages and bronchial arrangement, whether they are in harmony always or not, considering when the heart is malformed at the intracardiac level. And I would appreciate your comments on that, harmony versus disharmony of the appendages and bronchs.
I think I can comment to that because Adrian makes a very good point. I emphasized in my own presentation that almost always when the heart is congenitally malformed, then we have harmony between the appendages and bronchial morphology. But in fact, Justin showed you a case where despite the presence of isomeric left appendages, there was disharmony. And in his case, there was usual bronchial arrangement. So it shows that the exception tests the rule. As you made a very good point there, Adrian, that probably the only rule that is 100% is that the coronary sinus is always absent in the presence of right isomerism. And that's also a very good point because the rules that we use are very rarely 100%. I think it's fair to say that in almost all the cases, and I thought, in fact, I'd made a mistake. I thought I'd said that always there was harmony, but I was pleased to see when I looked at my images again that I said almost always. So I managed to get myself off the hook there. I was very worried that I'd made a fundamental mistake. So I did say almost always. But it indeed is the case that almost always there is harmony, but in those rare cases where there is disharmony, then it is the appendages that tell us what is going on in the heart. But of course, we need to take note also of what's going on with the lungs, with the bronchuses, and as Justin showed us, when we have a computed tomographic data set, you can see precisely that. Justin, I think you're muted at the moment. Maybe you'd like to say a few words. You don't have to wear your face mask anymore. The Florida judge has permitted you not to wear your face mask. And you see,
I told you there's a lot of things different in Ohio, not only wearing face masks, but also the weather. We had snow the other day. Compared to Florida. But yeah, you had just emphasized before you spoke, I was going to pipe up and say the case that I had shown demonstrated the rare instance of disharmony between the atrial appendage morphology and bronchial morphology. So I have nothing to add past what you just emphasized.
But it's fair to say that if the intracardiac structures are normal, then the harmony between the appendages and the bronchial arrangement is stronger than in case where there are other intracardiac malformations.
Right. Yeah, I think we all are in agreement that the most consistent features are the bronchial and atrial appendage morphology, and one of the most inconsistent features being the abdominal and splenic morphology, which has historically been used to subcategorize heterotaxy. And that's been one of our points we've emphasized recently, that when you describe these different visceral morphologies, then the additional term heterotaxy doesn't add anything to the diagnosis and may in fact just cause confusion. As opposed to just explaining the morphology.
Yeah, actually, in my video with azygous continuation, that specimen had isomerism of the left atrial appendages, but there was no spleen in that case.
there you go. There you go.
One simple question about the left superior caval vein persisting and draining to the roof of the left atrium. Is that the case that the coronary sinus, in those cases, the walls of the coronary sinus will always be fenestrated or unroofed in these cases, or there are rare instances where there are walls formed for that coronary sinus all the way to the mouth in the right atrium?
I think the walls, in all the cases that I have seen, as you say, the walls are either fenestrated or are represented by no more than strands. I've seen cases with just strands. I think, Diane, in your case, you demonstrated in one that there was a small strand at the orifice of the left superior caval vein, was there not?
Yes, there was.
So I think that you have to have absence of those walls between the coronary sinus and the left atrium. And it's two walls that have to disappear. And this is the interesting thing. But I think we can see with the fenestration that perhaps there are small connections initially that develop between them, and then they expand, and then the entirety of the walls disappear. Grace, do we have any more questions, or do you want to make any comments?
We have one interesting question is on the chat. I just need to find again, but she's asking when we don't have the coronary sinus, where the coronary veins are going to drain.
A very good point.
Yes, it is.
But the coronary veins will drain through the vestibules, although in some instances, and this is something we looked at quite a long time ago now. The initial work that we did on these features were done when a Japanese worker was working with me at the Royal Brompton, Hideki Uemura. And it was Hideki who made the point to me that when you don't have the coronary sinus, where do the coronary veins go? They drain directly into the atrial chambers. Someone also made the point, do you have a coronary sinus in left isomerism? In fact, in left isomerism, both of the caval veins are trying to be coronary sinuses. So you can have a coronary sinus in the setting of left isomerism, and often the other superior caval vein is unroofed, and I've seen strands in the other atrium. So yes, so you can have a coronary sinus in left isomerism. You cannot have a coronary sinus in right isomerism. When the coronary sinus is absent, the veins drain directly either into the vestibules, or they can run up within the atrial walls, and they can drain at quite a distance from the atrioventricular junction. And that's another very important point.
And we have another question from Pranav asking if the Eustachian and Thebesian valves have any function.
Well, they have bad function. It's interesting. Diane showed you that exquisite case. There was atresia of the Thebesian valve, and she showed you very beautifully in that case that the persistent left superior caval vein is then the only way that the coronary venous blood can get back into the heart. And she made the point in that case that the persistent left superior caval vein became very small, and she put the fetal demise down to that feature. I mean, so do they have a function? They have bad function because they can persist as the so-called Chiari network. The Chiari network can then become aneurysmal like a windsock, and then that can prolapse through the tricuspid valve. It can block the tricuspid valve. On occasion, it's even been described producing right ventricular outflow tract obstruction. So sadly, when the venous valves persist, they tend to produce bad things rather than good things.
Okay, and he has another question that I didn't understand very well. The coronary sinus apparently has a striate muscular sleeve and can be a source of failure of the Mays operation. What could be the origin of this muscular sleeve, and what happens in atresia of the coronary sinus?
Well, it always has the muscular sleeve, in fact, is the wall of the coronary sinus. For quite some time, it was thought that there was a common wall, a wall that was shared between the coronary sinus and the left atrium. We now know that that is not the case. Diane spoke all the time in the heart. She was dissecting that the coronary sinus had separate walls. So it is the separate walls of the coronary sinus that is the so-called sleeve. I didn't know that. I'm not quite sure about the significance of that to the Mays. Adrian, do you know anything about that?
No, it may be something in the adult world, not in the pediatric one.
Indeed. And of course, the maze procedure is very much a problem of the adult's cardiac surgeon rather than the pediatric cardiac surgeon. So I don't know anything about the relationship to the maze procedure, but it is the case that the coronary sinus always has its own walls.
Okay, amazing. It was a very nice session. Very, very nice session. We learned a lot. And I'm sure all the other sessions of the series are going to be as good as this one. So please, everybody, share the link of the video on YouTube to your colleagues. And we need to watch this lecture again, because there was a lot of details that are very difficult to pay attention and understand very well. I want to watch it again to be able, I'm going to get every detail. It was amazing, guys. Thank you very much.
Thank you, Grace. Just before we go, our next one is going to be May. Can you remind us of the date, Grace? I think it's May.
Yeah. It's May 27th, pulmonary venous anomalies.
Correct. So we will be ready for you then. And we hope that we will be repeating. Well, we hope Justin will have his Zio station up running by then, and that you'll be able to find us some nice example of pulmonary venous anomalies, Justin.
That's the hope. Yeah.
Is it up and working yet?
Still waiting for IT to create the pathway from our PACS to the Zio station, but hopefully in the next week or so.
Well, we keep our fingers crossed, but thank you for the splendid images you showed us today. And thanks to everybody for taking part. Grace, thanks for your coordination. We'll see everybody at the end of May.
Thank you.
Thank you.
Bye-bye, everybody.
Bye-bye. Thank you.
Bye.